Coming to the applied aspects of the larynx, there can be laryngeal atresia and stenosis. Because if the recanalization of the larynx doesn't happen at all, then there can be atresia. That is occlusion, atresia is. So leading to obstruction in the upper respiratory tract. So the air that is being taken from the nasal cavity doesn't go down because of the atresia of the larynx. So this is called as congenital high airway obstruction syndrome, which has to be dealt with surgically and as an emergency procedure. Laryngeal web. When the recanalization is partial, then there is a part of this epithelium that has been occluded. The lumen may persist like that, partially obstructing the airway. That is called as laryngeal web. And this is usually seen near the vocal fold. And there can be one or more laryngeal cartilages being not developed at all, which is a very rare condition, but yes, it can happen. There can be a double larynx, or a part of it may be doubled when the retinoic acid and the transcription factors are more than what they are required. There is stimulation of that particular epithelium in the floor of the pharynx, and that can give rise to the double diverticulum development, which can form as double larynx. And laryngoptosis is the descent of larynx much below the anatomical level. And laryngocele, that is when there is the more swelling of the recesses of the larynx or the ventricles of the larynx that are formed and are seen laterally on the neck. They are called as laryngocele. So yeah, this is what is laryngeal atresia. These are all the endoscopic pictures. So this inlet of the larynx is totally occluded by a membrane, which is nothing but the epithelium that has proliferated rapidly but not recanalized. So this is called as laryngomalacia, and this is called as laryngeal web. This is the laryngeal web. Okay, so there is a remnant of the proliferated epithelium between the vocal folds, obstructing partially the lumen of the larynx. So this is what is the laryngeal web. It can be total, a thick membrane, or a very thin membrane, where partially it may be open in various places. So this is what is called as laryngeal web. Laryngeal ventricle or the laryngocele. So when there is increase or the ballooning of these ventricles, when there is obstruction in the lower respiratory tract below the vocal cords, the air which has entered into the larynx also aerates the ventricles of the larynx as well. So when there is no proper entry of the air from the larynx to the lower respiratory tree, then there is bulging of the air that has accumulated within the ventricles of the larynx, or maybe due to severe cough and chronic cough. All these things will again get back to the smoker, that the cigarette smoking, and the people who blow more, that's bagpiper, or the who blow into the pipes. Okay, so then what happens is there is ballooning of this larynx seen like this, and this is how it appears grossly on the one side of the neck. It is usually unilateral. So you should be able to differentiate between the thyroid swelling, that is the goiter, or the laryngocele. You can auscultate on these laryngocele to differentiate both the diagnosis, differential diagnosis. So this is what is laryngocele about. Now coming to the development of further branching of the respiratory system. So this laryngotracheal groove that has been formed deepens into a laryngotracheal diverticulum or the respiratory diverticulum. So there is a depression that appears, a groove that appears between the developing primitive pharynx and the respiratory diverticulum on the sides, which is called as tracheoesophageal fold. So this tracheoesophageal fold on either side will grow medially towards each other to form a tracheoesophageal septum, separating the developing respiratory diverticulum from the developing esophagus. And now this the respiratory diverticulum is called as laryngotracheal tube. And this septum starts separating the pharynx from the respiratory diverticulum from caudocranially, separating it from the esophagus that is present dorsally, where the separation gets restricted at the laryngeal inlet. So this respiratory diverticulum will be communicating with the developing pharynx or the developing foregut at the floor of the pharynx between the sixth pharyngeal arches as laryngeal inlet. So as it develops downwards along with the elongation of the esophagus, the cranial part of this laryngotracheal tube will be developing into larynx. The caudal part, the distal part of the laryngotracheal tube will be dividing into two lung buds which proliferate for the future respiratory tree or the bronchial tree divisions. So the intermediate part of the laryngotracheal tube will be developing into trachea. And the lower lung buds, they divide into two principal bronchi and enter into the developing lung, that is into the pleural cavities, and then they further divide into secondary and tertiary bronchi, and then the mesodermal mass that is surrounding around these buds now are called as lung buds. For this process of branching from the lung buds, the SHH, that is the sonic hedgehog gene, which modulates the fibroblast growth factor 10 that is present in the surrounding mesoderm, is responsible for the branching of the bronchial buds. So the mesoderm that is surrounding the lung bud primarily is responsible for the further divisions of the lung buds. So in the embryonic condition, if you see, there is symmetrical division of the right and left lung buds into three bronchi. That is the primary bronchi. on both the sides, except for the division that on the right side, the cranial most division is separately present from the second and third. That is the very reason the right lung has 3 lobes. And when we come on to the left side, the cranial and the middle bronchus, they arise together with a same stem, and the inferior bronchus is separate in its division. That is the reason there are 2 lobes for the left lung. Since this higher division of the secondary bronchus on the right side is separate and is more cranial, it goes above the division of the pulmonary artery. That is how on the right side the bronchus here becomes eparterial and hyparterial. Since on the left side both the above and the middle divisions, the secondary divisions, have a same stem and is not more cranial and they are associated together, they are below the pulmonary artery. So there is only one bronchus that is present below the artery. So all of the bronchi here, the secondary bronchi, are hyparterial in the left lung, whereas for the right lung only the cranial most bronchi becomes eparterial and the rest of the bronchi, the second and third divisions of the secondary bronchi, become hyparterial. So these are the 2 images that can be very clear to you about the hyparterial and the eparterial bronchus, how they are formed on the right side. So when you see the gross structure after the development, from above downwards on the right side, there is an eparterial bronchus, the pulmonary artery, the hyparterial bronchus, and the inferior pulmonary vein. When you come on to the left side, there is a pulmonary artery, bronchus, and the inferior pulmonary vein from above downwards. So when you see from before backwards, it is the superior pulmonary vein, the pulmonary artery, and the bronchus. Similarly here, it is the superior pulmonary vein, the bronchus, and the artery. The division will be here. Yeah, vein, bronchus, and artery also is seen one after the other from before backwards in the left hilum also. So as the laryngotracheal tube proliferates and forms the trachea from the lower end of larynx, that is from the cricoid cartilage level onwards. So the cricoid cartilage is having cartilage all around the lumen. So the mesoderm, the splanchnic mesoderm, beyond the level of the cricoid cartilage or the larynx caudally, will be proliferating to form cartilage all around in a horseshoe shape where there is deficiency of formation of the cartilage from the mesoderm posteriorly, which is compensated by the formation of smooth muscle between the 2 posterior ends of the developing cartilage. So that's how the trachea will have a C-shaped cartilage where it is deficient behind and is compensated by the presence of smooth muscle, which is again very necessary for the functioning of the esophagus. So this is the high-end picture, the ultramicroscopic picture of the developing trachea. This is the same picture over here. So there is irregular plates of the cartilage that they are formed initially, and they all will join to form a C-shaped cartilage of the trachea, where the posterior ends will be joined by the smooth muscle. And coming to the epithelium of the trachea, that is lining, it is also developed from the endoderm of the pharynx, which is distal to the larynx. And the cartilages, the muscle, the glands of the larynx, all of these, and the connective tissue, all are developed from this planktonic mesenchyme. So what can happen if there is no proper development of the trachea, or during the development of esophagus and trachea, which go parallelly? So this will lead to formation of tracheoesophageal fistula. That means there can be attachment of the esophagus to the trachea, and this communication is called as fistula. Or there can be esophageal atresia. So the recanalization of esophagus, if it is not done in its normal way, there is atresia of the esophagus. So this development of trachea and esophagus can be associated with atresia of esophagus and tracheoesophageal fistula together. So the most commonly what happens is this type of the tracheoesophageal fistula, where the lower end of the trachea has the opening of the esophagus here. This will again relate to the presence of the TBX4 transcription factors and the retinoic acid. And this is mainly can be because of incomplete separation of the tracheoesophageal fistula from the esophagus and trachea. The tracheoesophageal septum, if it is not properly formed or properly separating the esophagus from trachea, these fistulas can be formed. And this can be detected when during the routine antenatal checkups, if there is polyhydramnios, where there is a lot of amniotic fluid than normally that has to be present, then it is called as polyhydramnios. That is because when such a type of a condition is there, normally the amniotic fluid will be swallowed by the developing fetus and will get absorbed, maintaining the amniotic fluid around the fetus. So when that sort of absorption is not happening within the GIT of the developing fetus, then there is accumulation of the amniotic fluid in the uterus around the developing fetus, which is called as polyhydramnios. So here you can very clearly see there is no connection between the upper and lower end of the esophagus. So there is obstruction in the cranial end of the esophagus, and there is communication with the trachea with the lower end of the esophagus. So this is the most common type of tracheoesophageal fistula that are usually formed. There can be this, which is about 4% that is seen, where there are two blind ends within the esophagus. The cranial and the caudal ends are not connected because of the improper recanalization in between, and there are no fistula that are present. That is, there is no connection of the esophagus to the developing trachea. And this is also very rare, where the upper end as well as the lower end is connected to esophagus, and the esophagus is extending from cranial to the caudal, except for an area where the esophagus is connected to the lower end of the trachea. Here is a very, very rare condition where the upper end of the esophagus is connected to the trachea, where it has a lower blind end. And here, similar to this, except for there is no connection between the upper and lower ends of the esophagus. So it is called as head-shaped fistula also, this one. Okay. So these are all a variety of the fistulas that can happen during improper septation that is happening between the trachea and the esophagus, or in between the laryngotracheal diverticulum that has been developing from the esophagus behind. So after postnatally, that is after the birth, the mother will bring baby to the pediatric clinic saying that whatever, even a spoonful of the milk that is being fed to the child vomits, and there is froth that is coming out of the mouth. That is because the froth is because it is combined with the air also. So that is the reason the froth comes out through the mouth, and there can be aspiration also that is seen through the nose, and there is shortness of breath, and the baby may go cyanosed because of the fluid that is entering into the lungs, and there is no proper gaseous exchange that is happening, which will lead to choking. And since the fluid is entering into the lungs, there can be pneumonitis which is formed and can lead to pneumonia. And these defects are associated with cardiovascular malformations, where they are called as Vater and Vactrial syndromes. In Vater, there are no cardiac defects. So there are, V stands for vertebral anomalies, A stands for anal atresia, T stands for tracheoesophageal fistula, E stands for esophageal atresia, and R stands for renal atresia. And Vactrial is nothing but all these anomalies plus cardiac and limb defects. So here, this respiratory abnormalities are most frequently associated with renal abnormalities in development, because the amniotic fluid content is maintained both by GIT as well as renal systems that are forming. So whenever there is the respiratory system abnormalities, they are always and usually associated with renal abnormalities. So this is all what we have just now discussed, and type A, how it is, type B, and type C is the most common type, which is depicted here, which is about 90%, where there is proximal esophageal atresia, as the esophagus will not be continuous with the distal part of the atresia due to the abnormal recanalization that happens with the esophagus, and the distal end of the esophagus develops a communication dorsally to the developing trachea at the lower end, almost at the carina. So this happens to be the most frequent type of the tracheoesophageal fistulas.